over to her. There we go. All right. Thanks for sharing, everybody. We are so happy to have Maggie King here today. She's a pediatric OT in the NICU at Baystate Medical Center in Massachusetts. She has 20 years of experience working in her field and has spent some time working with babies born with an omphalocele. Today, she's going to be sharing some of her insight about caring for those babies with all of us. Before she starts, I just want to remind everybody that Maggie is an OT, but she is not your OT. So she's not providing any direct medical advice today. She's here just to share her own personal experience with all of us. So please direct any specific questions about your own circumstances to your own providers. All right, Maggie, I will turn it right over to you.
All right. Welcome, everybody. I'm so excited to be here with you all, and I'm grateful to Christina for asking me to be a part of this talk today, and for Melissa for allowing it. So like Melissa said, I've been an OT 20 years in the NICU. I've been an OT for 30 years, which sounds strange because I used to be the young one, but now I'm not, and that's okay. But anyway, 20 years has been predominantly in the NICU. So I've had the privilege of seeing a variety of diagnoses and babies of all shapes and sizes and different surgical conditions, everything that one might see in a NICU. So first of all, I just like to say it really is a privilege for me to be a part of your journey, even if it's just one little snippet you take from it. The resilience that I have seen through the years of parents, grandparents, caregivers, siblings, whomever else is with that child, is very special and amazing. So don't ever sell yourself short, even on those dark days when you're don't understand what's happening or you're worried, and you guys are going to come out of this stronger than you ever thought. Not that we, ask for these things to happen. We don't, but you're going to do good things and you're going to come out good and strong. So for what that's worth. So a little bit about what I do in the NICU. So many of you might know, or you might not know, but all level 3 NICUs in the United States anyway, require that therapy is involved in the NICU. So level 4, I don't know where your babies have been or where they're going. Level 4 NICU is like a higher level. Most of them around are level 3s in some of the smaller cities, but Boston, where I'm near, Hartford, those are level 4 NICUs. But that doesn't really matter. But therapy is involved in level 3s and level 4s, which I believe your babies were in or will be going to. So that's just good to know, especially those that haven't delivered yet. Every NICU is a little different with regards to therapy, how they're utilized and who's in there. If it's an OT, a PT, a speech pathologist, sometimes all 3. I just ask your provider or your nurse, like, hey, is therapy going to get involved with my baby? Some therapists start off itty bitty early at the very beginning of your baby's delivery. Some may not get involved till a little bit later. All those things are normal. It's just a different culture in every unit. So I would say the first days in our NICU, when babies are born and when we either know or it's a surprise, it's rarely a surprise, but we do have those if a mom didn't have prenatal care. When I hear the diagnosis omphalocele, I immediately, in my brain as a therapist, go, oh, I need to know that baby. So, because things start off really early, not in a bad way, but there's things we can do as therapists to help promote your child's development. And that's really our goal in therapy, is to get out of the NICU on a good path to good development. So early on, and many of you may have experienced this, you may not have, and hopefully the babies that are still to come, that you will get some kind of support from somebody like me. Positioning is a really big thing when babies are first born. I'm mad at myself because I left my actual dolly at home, or at work, but I do have this one. So I dug this out of my daughter's old memory stuff today. But typically, we still see it sometimes, but not as much as we used to. But babies would come out and they would just be kind of in this flat position with these arms out to the side. The legs might be out a little bit. Their heads flat on the mattress, kind of in the position of this dolly, which is fine for just a little bit if the providers are doing work on your baby or on their abdomen or doing whatever they need to do. But after a few days of that, muscle tightness starts to sit in. You can just have some changes that people like me know. It's not necessarily the doctors and the nurses. Well, the nurses have gotten really, really good. But so one of the best things a nurse or you or whatever the doctor, whomever's caring for that baby can do is position that baby where they're in midline, meaning, their shoulders, hips, knees, ankles are all in alignment, and that they're have some containment. Every unit has a little bit different positioning strategy. Some are in snuggle ups and bendy bumpers. Some have we have dandle wraps and frog positioners. Some units might just have blanket rolls, which work too. You don't have to necessarily have all the fancy stuff if your hospital doesn't have it. But the idea is that these babies are contained, similar to being in utero, in the womb. And then we also want them to the best of that baby's ability to be in some sort of flexion. So not here, but in and with those arms near their face, if they're allowed. We'll talk about that in a minute. And then those legs and hips, bent in a fetal position. That's the aim. That's a little difficult when you have an open abdomen with an omphalocele. So I would say it's kind of modified. You just work, and you're not going to be doing this yourself. This is going to be driven by nurses or a therapist, but you can ask about it. If you notice your baby is struggling to stay calm, or their arms and legs are flailing, you could just ask. So, oh, hey, I was on the support group, and is there any way we can make him a little bit more, he or she a little bit more supported? So those are questions you can ask. But it is sort of doctor specific too. Like a lot of the surgeons want that area open and nothing touching, and we have to go by what the surgeons kind of want, but we can still position those arms. We can give the babies maybe a little roll or something to push against their feet. And we certainly can put something at the top of their head, whether it be we have these little frog positioners, or a mom's hand or a dad or grandparent's hand can serve as that, just to give them that supportive flexion. So that's really important from the get-go, because I think, and I was going to say too, I'm very conversational in presentation, so just beep in with questions or thoughts, because that's just how I do this. So what else was I saying? Oh, I think many of you may have experienced this or will. I hope not, but I think there's that thing, you have this beautiful baby that you've been planning, and then all of a sudden, those things are kind of taken away from you. Oh, we can't touch him right now. We can't hold her right now. Oh, we got to be quiet. Oh, no, you can't FaceTime grandma. Whatever the situation is, there's a lot of things taken away. I have not had a child in the NICU, but working with other parents, I've seen that happen, and we've talked about it a lot. So, just keep in mind though that your baby knows your voice. There's studies that have proven that. They know everything about you, and you're still their most comforting person. They've been with you for, 7, 8, 9 months, maybe younger. And they know you more than they know me, more than they know their favorite nurse that's there every week. So keep that in mind. I hear that a lot from parents. And what if they forget me? They won't. So that's very important to know. And then your touch, like even if your baby can't be moved yet and can't be held, or for whatever reason, you can still put your hand and hold them in the warmer that they're on, or the isolate, one hand at the top, maybe one hand holding their hand, or facilitating that palmar grasp when they grip your finger. That's a very neurologically calming thing for children, kids, babies, adults. That's what we do when we're stressed. We come in. You might even just hold a foot for 30 minutes, so even though you might not be able to hold your baby, you can still provide them, support and holding, and your hold on that foot or that hand or whatever's available to you is more important than anything. So, and I feel like NICUs have come a long way, where, I started seeing in the beginning of my career, but I think we're getting better and better at family-centered care, that maybe we can't have you do X, Y, and Z because the baby needs to be in a certain position, but you can do these things. So, I just encourage you to ask the questions, and the nurses are your kind of your person. The doctors are amazing and have all the knowledge, but your nurses are kind of your person that's going to help you with engaging and being a part of your baby in those early days. Another thing with positioning, we'll talk more about this in a minute, is if your facility has gel pillows, for those of you that haven't had your baby yet, gel pillows can be helpful. They don't completely create an in utero situation, but when babies with omphalocele come out and they have to be on their backs, unfortunately, for a while. We'll talk about how we can change that up a little bit, but in utero, they're in an aqueous water solution, so we can't reproduce that. But gel pillows do a little bit of the job. So I would ask about those too. Again, it's not all on you to ask these questions. I just want you to be aware of what's out there. So maybe something does come up and you could ask about it. Also those early days, and I'm talking like the first couple days in a NICU setting, decreasing stimulation is also very important. Your baby and you just went through a traumatic thing and are being delivered maybe early. But even if they're term, there's a lot going on. There's lots of IVs. There's lots of people poking and prodding. There's lights. There's just people, and if your baby gets intubated or has to have, other respiratory support, there's a lot of people involved with your baby, a lot of touch. So what we can do as providers, as parents, is to just keep your like your voice can be really calming, but not multiple voices. So maybe mom comes in, then maybe dad talks, then maybe grandma talk, like just one at a time. Also, it's real common as parents to want to stroke your baby. Oh, you're so cute. And they are so cute, but stroking, they didn't have stroking in utero. They were hugged really tight. And I wouldn't say you shouldn't ever do that, but in those early days, it's going to feel best to your baby to just have firm hands, just still hands. You can watch even your monitor on the baby and you'll see some of their numbers improve just by this kind of touch. So if you do some stroking, the baby pulls away from you, it's not that they don't like you. Okay. And I've heard that from multiple parents. It's not that they don't like you or that you're doing something wrong or that you're hurting them. It's just how even as adults, we get kind of like, ugh, like if we're overwhelmed, overstimulated, we have too much going on, or it's too noisy, or the kids are being loud, we feel that way. And we have mature neurological systems. Well, these babies, if they're immature, they have immature neurological systems. And if they're term, they're fresh, they're brand new, they're still trying to learn how to take in sensory input. So, we don't play music in the beginning of the days. If we, even having your phones have become a kind of a controversial subject in the NICU. But FaceTime and stuff with grandma, or if a parent can't come, or grandpa or whatever, that's important, but you have to be mindful of the sound, the volumes, and just keep things to a minimum. And you can blame that on us. You can say, oh, the doctors or the nurses or the therapist said we can just kind of do a quick little check-in. Use us, we don't care. So let's see, the other early days. So we talked about positioning, decreased stimulation. And then the other part about positioning, I would say, is I feel like this is also getting better, at least in the place that I work, but just because they have an omphalocele doesn't mean we can't move your baby. There can be itty bitty movements of the neck, just the neck rotation is really important, or maybe, bringing those arms in or bringing them up to the baby's face, even a little bit with the legs, depending on the size of the omphalocele. Sometimes that can interfere with some leg movement because you don't want to get too close, or because it might be uncomfortable, but you could do little bicycles with the baby. You can, with the doctor's permission, get them in a modified side position, just something to change their posture. Any of us, we're all humans, and our little beautiful babies are brand new humans, but we all move. We all have muscles and tendons and joints that get tight if they're in the same position for a long time. So, I think if you I feel like I'm talking to most of the people that haven't had their babies yet, but I think talking with your nurse again, or your therapist or whomever about what can I do? What can I do early? Because there's little things you can do, which is going to be beneficial for your baby. So any questions about like those early days or thoughts on that or your experiences with that? And if there aren't any, that's okay too. All right. So jump in if you think of something, okay? So the first, everybody's in the unit varying amount of times from days to weeks to months. And some babies are going right to the OR, some have to wait a little while, some have to wait a long while for surgery. So I feel like there's an array of babies with different issues. But I think ultimately, as a therapist, it all comes down to the things I've already talked about as positioning, stimulation, either lack of or too much, and comfort and parent confidence too. I mean, I can't imagine. I mean, I've seen a lot of omphalocele and it almost becomes like, okay, I've got a baby with an omphalocele, but I know for you guys, this is your baby. And that's, I can't imagine what that must feel like. Like, oh my goodness, but they do amazing things and they participate in an amazing life and they do well. I've seen so many babies down the road. So those first weeks, days, however long a baby's in the NICU, positioning continues to be very important. Some of the things that I can see that happen positioning wise is, I kind of alluded to it, but we're going to go a little bit more in depth, is babies will get tight shoulder retractors. So your shoulders are, well, it's your scapula. Your scapula retractors are right here on your shoulder blades, on your wing bones. So if a baby is constantly on their back, even with their arms down to the side, and they don't get that rounded position, that can become a little bit of an issue. And we do see that a lot in surgical babies and things that need attention on the front. So whenever you're holding your baby, once you're allowed to hold and do other things, that would be an amazing thing to do. Like, even if you don't want to get anywhere near the stomach, get these arms together. And it's not just like hand to face, it's really from behind, getting those shoulders off the mattress, basically. That's a really good thing. Even when you first get home and in those first few months, that's a good thing. That's good for us as adults. We we get tight too. I might have a kitty cat that comes across the screen. We'll see. He wants in on the action. So shoulders are so important. So our whole life as humans occurs in the middle. We bring our food this way. We do everything. We bring our hands to our mouth. If we're nervous, we might chew on our fingernails. Everything's in the middle. We brush our hair. We read a book. So if your whole life is out like this, that's going to be hard. So starting that early shoulder protraction or rounding, just think of shoulder rounding, is really important. So the neck, again, I talked about it again, but let's spend a little bit of time on the neck. I'm imagining that some of you, and I know some of you have had issues with head molding or needs for helmets. I think this is a population of babies that it's a little bit higher risk. And that's because most of that early time is spent on a baby's back. And then it's that, but it's also when you get home, the tolerance for tummy time or the fear of tummy time, there's lots of different reasons, will put the baby on their back more. So it's nobody's fault. It's not the hospital's fault. It's not a parent's fault. It's something that happens because a baby's hasn't spent a lot of time on their tummy. So, but usually, like, so when the baby gets like the back of their head is flat completely, that's from being on their back all the time. So we'll talk about this in a little bit, but tummy time up on your chest, if that's allowed, we'll give time off the back. But it is really important for me to say, as well as all medical professionals, that safe sleep is the most important thing. Babies have to be on their backs to sleep without anything in the crib. We use a lot of positional aids in the unit, in the NICUs, but once you're home, they don't they're not safe. Like they're safe in the unit because we have monitors and we're watching them 24/7, but when they're home, they really need to be on their back. So that has saved many, many lives, many babies. I think the SIDS rate's down by like 85%. It's probably more now. So if we have a flat head, that's much better than a really horrible incident. So for that, that's my little back to sleep plug. But the other kinds of flat spots that can happen with babies, especially with surgical babies, would be if they have one side that's flat, called plagiocephaly. Very common. It's very common in NICU babies. It's very common in newborn nursery term babies that don't have NICU stays. It's rampant, actually. We see it all the time. But where those flat spots happen are primarily from the neck. The neck gets tight. So if your baby's, in the NICU or beyond, and they get a little tight with their head one way because they've kind of always gone that way, that's their comfort place, then that muscle in here gets shortened. And then every time they lay down, go in a crib, go in a car seat, anything, they tend to just go here. So that's what causes some of those spots, is that part of their head can get a little flat. So really early on in the NICU and beyond, working on your baby turning side to side, I need that. That feels really tight. Is really important to start early on. So some of the ways you can do that in the NICU or beyond is alternate which side you have your baby. Like they're going to start looking at you and turning to your voice. So sometimes hold them in this arm, sometimes hold them here. That'll encourage some neck rotation. Once you're approved for tummy time, and I'm getting to that, if they're up on your chest, sometimes have the babies rotating their head face to one way. And then after 10, 15 minutes, or the next time you hold them, you're going to go the other way. So if you can keep your neck range of motion good, those flat spots are going to be hard to develop. So you could also, if your baby's like in a little seat or on the floor playing and you're folding laundry or doing whatever life skill you have to do, position baby where they have to turn their head towards you. So that's not always the same. That helps too. And it's hard. Believe me, I look, my baby's 16 right now. And I remember looking at her one day when she was a little person. I'm like, oh my gosh, I think her head's a little flat. It's like, we do this for a living, but it happens to everybody. It doesn't make you that you miss something. And especially with babies with omphalocele, that's a big deal. That's a really big deal. I hate that you guys had to know about it. I really do. That makes me sad, but your babies are amazing and they're strong. And you are too, but the rest of the world doesn't know that happens. I don't know if you guys have seen that, but people don't know about it. So this is really awesome to have this support group. But it is a big deal. So your baby getting out of the NICU and getting home and being fed and engaging and talking and smiling and doing all the baby things, that's the goal. If you have a little bit of flatness on a head shape, it's okay. Like those things can be worked on, and that's just not the goal. The goal is to get home and to thrive. And everything I've seen in my practice with babies with omphalocele, they're all thriving. They're all beautiful babies. So for that, that's what I'll say about that. Okay, so that's all the stuff about positioning, positive touch from parents, like we talked about, whether it be holding a hand, a head, whatever you can get involved with. Your nurses should get you in there early in most situations. There are some situations, I suppose, where if a baby's really struggling, meaning they're sensitive or they're just not tolerating touch a lot, there are cases where they might say, you know what, we need to let baby just be. They had a hard morning. We had a lot of tests, and that's okay too. But just being there or reading a book or journaling, I've had lots of moms do that, or write out all your questions or whatever you need to do. Just being in their presence is parenting that child. So keep that in mind. Even if you can't do a lot with your baby in those early days, there's still lots you can do next to them. I think that's really important. And then also the first weeks, first days is positive oral motor stimulation. I was just telling the group before you guys got on that feeding, I'm really passionate about feeding because we love to eat. I don't think anybody on here doesn't like to eat. You know, I'm just going to make that assumption. It's just fun. It's fun to try new foods and it's fun to eat. And that's the ultimate goal for all of our babies. And there are lots of situations that can produce feeding aversions, sensory issues. And any baby that has something going on, you know, in the beginning is at risk for that. Well, there's certain lots of kids too that don't have a NICU stay that are at risk for that too. But so your baby, depending on their needs, may have tubes in their mouth, tubes in their nose, suctioning. You know, they have an open abdomen unless it's been closed. Everything attached to the feeding issue, like I mean from mouth, throat, esophagus, tummy, bottom, anus, everything in that situation affects feeding. So I think early in my career, I think that was a big aha moment for me. Like just because the baby now is allowed to bottle or breastfeed or whatever the situation is, doesn't mean they're going to be good at it. And now having years of experience, I see that it's just anything in that tract, in the feeding tract, if anything's off or has needed attention, feeding's going to be affected a little bit. So positive oral motor stimulation could mean a pacifier. It could mean bringing your baby's hand up to their mouth so they can just do some of their own exploration or sucking or licking. You could even just give them some like just little pressure to their face, not stroking, but even around their lips, just something positive. They've had so much negative. So those things can help. Again, not all day long. If your baby's calm and happy and just in a nice place, you could just put a hand on their face. That you're promoting good feeding that way. Let me turn my notes and tell me if I'm going too long. I get really excited about this stuff. It's my favorite stuff. So, you know, the whole feeding thing, and you all as parents and parents to be know that, I mean, feeding's huge. These our babies with omphalocele don't get to eat right away because that whole system has to rest, or they're in surgery, or they're, you know, it has to learn how to digest everything because it's just different. Everything was born on the outside, and every baby's different, and every doctor and surgeon might have a little bit different tweak. But usually, and correct me if I'm wrong, parents, like usually it takes a little while before they're allowed to eat, meaning just getting something in their belly, not necessarily a bottle or a breast, but just getting milk through the nasal gastric tube or the oral gastric tube. But we can still work the pacifier. I think if you're into pacifiers, some people don't like them. You could have, you know, a baby's hand to their face to kind of act as that, as long as it's kind of supervised. Nurses, and I love my nurses, they're some of my bestest friends, but they're very protective of all their tubes, as they should be. So they might say, oh, no, we don't want his hand near the mouth. You're probably going to hear that, or some of you have already heard that. And that's for protection too. We don't want tubes coming out because that's more intervention, maybe even more x-rays for your baby. So everything's within reason, but your nurse will help you, or your therapist, or, you know, somebody will help with those things. So just keeping in mind too, like non-nutritive sucking is our pacifiers. That's what we think is non-nutritive sucking, or on the hand or wrist or whatever. And that's a pretty easy skill. Babies get that at about 19 weeks gestation. We know that from ultrasounds because they're sucking on their thumbs or their wrists or their hands. So they've been sucking for a while. So that's good to encourage. It's very calming. It's very we call it like self-regulation, or neuroregulation, helps keep people settled, or babies settled. The next step from that would be, if the baby's ready, is to do some like pacifier dips. If you're not into pacifiers, you can maybe put a little something on a baby's hand and let them kind of lick and taste, because that changes it. It's like, oh, there's something to this non-nutritive sucking. There's a taste now. That can be really, really effective. In most units or situations I've been aware of, like once the MD, the doctor, approves it, they can have little tiny drops of milk, colostrum, breast milk, formula, whatever your baby's getting. And most of our babies do love that, but that doesn't mean they're ready to eat yet. But we're warming up the mouth. We're warming up that digestive tract, that abdomen, the whole tract to get them thinking about feeding. So, and those breastfeeding trials are tricky too. I don't want to leave that out because breastfeeding is really awesome for your baby, and many a mom really, and dad, look forward to that. And then when you get a diagnosis and it kind of changes a lot of stuff, that often can be taken away too. So I think that has to be directed again with your doctor, the surgeon. I think when you're making some decisions, you can talk to them like, hey, this is really important to me. How can we make this happen? And I would just put it out there, and I think it can happen. I think it's difficult, but it can happen. So I think why it's difficult is in the early days when babies with omphalocele are starting to take food in, the surgeons and the doctors are very specific about how much they can have. Because if a baby after surgery takes too much in, it could lead to vomiting or intestinal issues. It's just very specific in those early days. So on a breast, you don't exactly know how much you're getting. But that's evolving too. I think every place might handle that a little bit differently. There could be, I can't speak for your places, but if a baby was able to take a certain amount of food now, like maybe they're up to an ounce, or I don't know what the magic number would be, but maybe that surgeon or that doctor would let your baby go to an empty breast for some oral motor stimulation and just getting drops. It also depends on your flow and how much milk you make. And because we may have a mom that overproduces, the baby potentially might be like, oh, I don't know what to do with all this. So that's where your lactation consultants and just different members of the team would get involved with. So I guess I'm just putting that out there. I'm more, as an OT, I'm more of the bottle feeding person, but breastfeeding is so important, and something that, it could be another thing that you put in your list of like, oh, I couldn't hold them right away. I couldn't breastfeed them right away. I couldn't do this right away. But I don't think it's off the table by any means. So I think that really is a discussion with lactation, your nurse, your therapist, everybody, to how that could become a goal for you. That being said, if that ship sails, and I don't mean to put it so bluntly, but if that just doesn't happen, or because of the stress, you didn't create a lot of milk, or you just don't want to do that, that is totally fine too. So I think, we don't spend enough time talking about that either. Like, these are major things. So that doesn't make you a bad parent, a bad grandparent. Just that is best, in my opinion. And I think when you're dealing with surgical procedures and things that take a little while, however you can feed your baby is the best thing, because ultimately the goal is for your baby to eat down the road. And I'm getting to that next. So anybody have any thoughts about that, as far as like what you've been through with breastfeeding trials? I'm limited to the kids that I know, but I don't know what other hospitals are doing. If you think of anything, let me know. Just thoughts. And I would like to know more about that, honestly. So with bottling, again, we kind of think like, oh my gosh, we finally get to give our baby a bottle, 10 cc's, 20, whatever it is, 5 cc's. And it's so exciting because it's, at least from what I see and what I've talked with parents, it's just such a normal activity to do with your baby after all this prodding and surgeries and this and that. And so I can't imagine what just feeding your baby must feel like for the first time. So I think one of my jobs as a therapist is to prepare a parent for what that might look like. Just taking a little couple licks or sips from a bottle or a syringe or whatever is really the goal in those initial feedings. There are some babies that might take off, like, finally you gave me a bottle, but I would say the majority of babies, it takes a little time to figure it out, because it's another thing that they haven't been able to practice. And it just takes a bit, and like I said, it all relates to your tummy, or something got off in in pregnancy and in delivery that I need fixed, and feeding will come second. So what we always recommend for first trials with any baby, but especially babies after omphalocele, is a slow flow nipple. All the NICUs have those, or they should. Slow flow nipples, we position the baby in sideline. So if you think of a natural breastfeeding position like this, so if you guys can see me, the sideline is really just bringing your baby out with support to that tummy. We probably would put some pillows or a boppy, and then we feed the baby in this position. The reason this is nice for an early feeder is the milk goes to their cheek first, then it goes to the back of their throat, so they can take their time to figure out what to do with that milk, because their pacifier didn't have milk in it. So it's like, okay, this is something new, and then they swallow. So again, we're trying to create something very pleasurable versus the typical position in this, when they're reclined in your arms. You'll get there, but those early days, it's too much for them. That milk goes right to the back of their throat. And I would say this about pretty much any baby, omphalocele or not. Like, it's a lot that just comes right into their throat. And sideline is just a really natural way to get babies interested in starting. And we do pacing strategies and different things. So yeah, so that first day, if you get 5 cc's in, or even 1 cc, or just they tolerated the bottle being in their mouth without any major issues, that's a win. So it's really quality over quantity. And that's hard because in NICUs, we preach quantity gets you out. Once a baby's up to a certain amount of food, they get to go home. But I would rather a baby take 5 cc's and be very calm and have good vital signs and be happy, versus a baby that has all kinds of issues of spitting and sputtering and having like oxygen issues, because we wanted to get the volume in. So, what I tell all my parents, I'm sure I told you, Christina, is that the main goal of these babies is to love eating. Well, that's not the main goal, but that's one of the main goals. So to avoid aversions, and aversions start early. And your babies are going to have a lot of negative things to their mouth and esophagus and suctioning. So when we get to the feeding part, keeping it as pleasurable as possible is really important, because I want your baby to want to eat ice cream. I want them to go to the fairs and to eat tacos or whatever your families like to eat. That's the goal. So even though feeding might seem slow at the beginning, and maybe a nurse or a therapist is like, you know what, we're going to stop. That's why. So it's not that your baby's doing poorly, or we just don't want to push them. There is a point sometimes where we push, or we try to wake up a baby a little bit more because they're just getting sleepy. But in those beginning days, it should be conservative. And they'll get there. And I love, can I talk about your baby, Christina? So Christina's baby was one of my little friends that I got to meet, and he came on before the meeting, and he's eating yogurt, and I've seen all kinds of pictures of him first French fry. Like, as a feeding therapist, I love that stuff, because when I'm giving your baby a bottle, I'm thinking about French fries. So because it's a good thing. So he's done amazing, and your babies are and will be doing that too. So what else? There's all kinds of things. So I'll go through a couple more things about tummy time and preparing for home, and then if there's specific questions, because I know I've gone over a lot of stuff. But one more thing about feeding, and I do remember this with Elliot, like, it just takes time. And I think it can be frustrating as a parent, and even as providers. You might have a really good feeding, meaning maybe they took all their bottle or they took most of it. And then you might come back the next day and they don't want anything. Those are hard days, I think, as a parent. From what I've heard, it feels like a setback. You've had this baby having some progression, and then they don't want it anymore. But feeding, also to keep in mind, is an aerobic activity. Crying and eating are really the only 2 aerobics a baby does. So, we do all kinds of things. We're walking to the bathroom, we go get the mail, we eat, we do all this stuff that's our aerobics, but that's all they get to do. And so it tires them out. So they might have a good day of eating, or even maybe a good couple feeds. And then they're going to be like, nope, I went to the gym today and I'm all done. So if you can look at feeding, even though your baby doesn't have, maybe they don't have any respiratory issues, they might though, because the tummy might be pressing up on the lungs a little bit, but either way, think about, uh-oh, there's a cat. Sorry, that was Oliver. Hi, Oliver. Think about your baby literally is at the gym. So all of us as adults, we might go to the gym, 1st of January, we're all excited. We're like, we can do it. You have a great workout. Your baby has a great feed. And then maybe another day they'll do another one. And then by day 3, they're like, no, I'm just going to watch Netflix today. So that's really honestly what's happening with them. They need a break. They need to rest. They haven't forgotten. They just can't do it all yet. So babies are really smart. When they're stressed or tired or fatigued, they don't do it. Many adults, when we're stressed, fatigued, whatever, we still eat or do whatever we have to do. So we should learn from our little babies. So just keep that in mind. If you see that or you saw that, it's very normal. So I know tummy time often comes up with babies with omphalocele or other abdominal issues. I would say in our unit, and Christine, you might need to help me with what we did with Elliot, but there you can't do it at the beginning. You just can't. You have an potentially open wound, or not wound, but an open cavity or a fresh surgical belly. So a surgeon's going to be like, huh, no, and that's fine. I wouldn't want to touch that either. I think it's important. We can deal with stuff later as a therapist, as long as we can get on some of those early positional things I talked about with the shoulders and the neck. But once they're approved, everything I do is specific to doctor's orders. So if a doctor, and in your baby's case is a surgeon, if they say they can move and they're ready and your baby, I know there's different degrees, like if your baby has full closure, and you might be able to start some tummy time. Sometimes it may not happen for a while. And I appreciate Melissa saying about, you really have to talk to your own providers, because like the early intervention community or the therapist that you might be seeing, like I'm the early therapist, those folks probably have a ton of different strategies that have emerged in the past 10 years that I don't know. They're pretty cool at coming up with things from within the home on how to help, but you can use boppy pillows, you can use rolled up sheets and blankets. The main thing, once your surgeon approves, is that belly is either lightly supported or has no, it's not flat on a mattress or on a floor. I mean, anything pressure like that, they're not going to probably like from a surgeon's point of view, and the baby might not like it either. So, if you get your baby kind of in that supported, that supportive flexion I keep talking about, and say they're, over a boppy pillow, but you have their tummy area kind of open. Again, if your doctor's okay with that, that's tummy time. You could do a modified. So if you think about your baby being on your chest, you could even do that. I've done that in the NICU a few times too, where, sometimes mom's chest or breast can provide a little roll like that, but just to create a little space where their belly is, with blankets, with rolls, that can be helpful. Even, maybe they're not in full prone, which means on their tummy, but maybe they're on their side. That could be another really good supportive positioning, or even side and slightly towards their tummy. Like there's ways you can start, like therapy is all about modifying, you do a little bit at a time. So that's all good, but I would just encourage you to, because everybody's different, what your doctors are allowing you to do, or what your EI or outpatient therapists, where they take you from there. But it's not off the table. I think it's off the table in the very beginning because it has to be, but there's other things to do. But then as your baby heals and as their skin heals, and they might not like it right away. I think as therapists, we're really promoting early tummy time, as supervised tummy time, as quick as possible. So our omphalocele babies, we don't do that right away, but I think it can be, based on your individual situations, it could be started, when they get home, or maybe a little bit of time in the NICU. Did we do any tummy time with Elliot?
Oh. No, we didn't do anything in the NICU. The surgeon did not clear us for anything, even on a boppy, until he had full skin closure. So
Got
we
it.
didn't do anything in the NICU,
Got it.
tummy time wise.
Okay, thank you for that reminder. So that's a classic example of, I'm not going to do that until surgeon says it's okay. But there's reason for that. So it doesn't mean it was best for her baby to be on his back or side until that closed. So that's going to be many of your situations, or was. So everybody's different in omphalocele. I've seen all different sizes and shapes and issues. I've seen babies go home with them very, very open still because they couldn't get back in. So there's a lot of stuff to think about. I think in preparing for home, my job is to get these concepts out there. We're talking about feeding, we're talking about positioning, talking about tummy time if it's allowed. But one thing you could do as a new parent is those early days, if you think about it, it may not be on your mind, but I'm not sure how it is in other states, but ask for an early intervention consult. Like if the case manager's coming around, or the nurse, like, hey, or the doctor, maybe the doctor, I want to make sure that you guys get EI rolling right now because you're going to need them. They're awesome. So early intervention, if those that you don't know, is a birth to 3 program that all babies can have. It's free. I mean, they do bill some insurances, but it's a government funded program for the most part. They come into the home. It's either an OT, a PT, a speech, or developmental specialist that can come in and help promote some of these things I've been talking about, and then promote further development. But I can't speak for any place but Massachusetts. I would say in our neck of the woods in Western Mass, sometimes it takes a while for EI to get started because A, there's a lot of babies, and B, it just takes time. There's not as much, there might not be enough providers. So if you could get that consult going early, likely by the time you're going home, they might be calling you sooner than later. So that's one suggestion I would make. The other one would be, sometimes it's not good to get out and about, but if you really are worried about something, or you notice your baby's neck is tight, or they really have some aversions to eating, or I don't know what the situation is, you can go to outpatient therapy. So there's OTPT speeches that can provide therapy before early intervention kicks in. I don't know about other states. Massachusetts, you have to choose either or, EI, early intervention, or outpatient. But I have some babies go to outpatient for a little bit before EI kicks in. ECI is what they call it in some states too. I don't know what they call it, but we call it EI. So that's one thing you can do. Also, like talking with your providers about the best nipple choices for home. Usually if a baby's rocking and rolling on a slow flow nipple, I don't like to change too much because we want to get these babies and families home. So there's lots of different recommendations for that. Some babies are going home on a regular flow nipple. It really just depends on how, not quickly, but how your baby advances with their tolerance for feeding. And if they do go home on a slow flow nipple, that's not abnormal or unusual. In fact, a lot of the newborn nurseries with the term babies, not NICU babies, are only using slow flow nipples. So it's not a bad thing. Car seats, that's a big thing that's come up. And I actually learned some of this from Christina too, but I know there's a specialized car seat for omphalocele that are, all I've heard is it's super expensive, really hard to get a hold of, I guess, and questionable on insurance and all that. So I have not seen that car seat. I know that it exists. I know for us as providers, many of us have felt uncomfortable. I can think of a particular baby that had very large open omphalocele that wasn't closed, and we had to get the surgeon to sign off on what they approved the baby to go home in because we were all nervous. We're like, we can't send him home in that, So I don't have a lot of information about how many people or what different hospitals have those car seats available, or did they go home in car beds? Is it not a big deal? I'm not sure what what you guys as a community are seeing with regards to car seats.
I will chime in here for a sec and just say that it's called a Jefferson.
Thank you.
Some use a Hope car bed instead of a car seat too, depending on size and age, and weight. Weight seems to be the big thing. But we, Warrior, we have a car seat pass down program. So if anybody's in a position where you think you are going to need one and you need help getting your hands on one, go to our website and we can help you get that situated. A lot of hospitals do have some that they will loan out. I know that's not always the case. Ours did. I've heard of a lot that do not. So I think it just depends on where you are, what level of NICU you're in, but we can help with that. If anybody has more questions, you're welcome to ask about that as well.
That's fantastic to hear. I think I would imagine that maybe some of the bigger urban hospitals, yeah. I always get urban, rural, which one? But like the Bostons, the Hartfords, Dallas, the big centers, I would imagine might be more apt to have a loaner program. But it is concerning, it depends on the size of the, omphalocele. But that, again, I would maybe not your first couple days because you're not thinking about that at that point, but as you start feeling a little bit more comfortable in the NICU and NICU discharge stuff will start coming up, your babies will go home. So at some point you could start asking about that or put that in your little list of questions. Like, okay, at some point we need to ask about this. Another thing that I don't know what they're doing in your communities and even ours, because I'm just in the hospital, but things like scar massage and different things for these tummies, because they do, anytime there's an incision or surgery or putting things back in or out, there is some level of scar tissue that could lead to like just some mild immobility issues. So again, those would be questions I would ask too, not in the NICU, but like once you're home and maybe at your pediatrician, like, is it okay? Can we rub stuff on this? Can we do some babies, like there's some therapists that do like myofascial things. I don't know what's happening in the outside world with that. Do you have information on that, Melissa?
We asked our surgeon about that actually, and he told us it's not going to make a huge difference in the immediate future. He told us not to even worry about it. My daughter was repaired at 8 months. She's 3 years old now. We haven't seen him in a while, but last time we saw him, he was like, she's still growing. Some of that's going to sort of rearrange on its own anyway. So I don't know, it might change a lot based on like size and surgeon and what their techniques are, I imagine. But for us, it was like not even a thing to worry about.
That's awesome. And I think that honestly, like even anything I'm saying too, is there's so many things that your baby's going to get through and do. And these early days have a lot of challenges, but I think it's just our job as therapists, nurses, doctors, surgeons, parents, just to take your baby through this journey and try to think of the little things that might affect them from having an open abdomen or an early surgery or being on their backs. But I'm telling you, like I said in the very beginning, the resilience, not only of parents, but these babies is crazy to me. They do so well. And maybe they'll just have a little scar. Maybe it's the cool story they're going to tell when they're in 6th grade. I don't know, but it's just, they're super babies, they're beautiful super babies. So I just think as we go through healthcare and stuff, we just learn more. And there's, people like myself or other disciplines that there's little things we can tweak to kind of help. And I hope that, especially for those that haven't had babies yet, that you'll have some therapy support in your NICUs. You should, I would think you will, the nurses are amazing too. Many a nurse do a lot of this stuff because they want to know this stuff or they've worked alongside a therapist. Let me just see if there's anything else. I think too, like core strength is often an issue. Like, your baby's probably going to have a little bit of core weakness. But I don't know. I mean, they once they get moving, even if they have a mild motor delay because maybe they didn't get to get closed up or they have spent more time on their back, they're gonna get it, like as long as they're neurologically intact or don't have other things going on, which, I hope and pray that doesn't happen. But if your baby, if this is their issue, is this omphalocele, they're gonna do their milestones. They might do it a little differently or a little bit late, but they're going to get them, you know? So, you know, core strengthening, that's a lot of early intervention stuff, but even just, you know, sitting your baby, you know, up on your knee or on your lap is going to work their core a little bit, or, you know, doing some side to sides, anything that kind of, you know, that's a lot of neck writing, but you could, once they get a little older, you can lessen that support where they have to, you know, hold that trunk steady, or you could do little baby sit-ups. Like I wouldn't necessarily pull them by their arms. We do this in therapy as a test, but I don't think parents should necessarily do that. But get behind their little shoulders and say they're on their back and just gently pull them up, and don't do it all for them. Let them kind of work themselves. You know, those are little baby sit-ups. Just modifying and putting your babies in lots of positions as best you can. Sideline where they're, you know, they're reaching for toys or for your face, or a lot of early interventionists or outpatient will have the physio balls. You can even have like a little beach ball and just sit them on that for some different, what we call writing reactions, where they're working their trunk. So yeah, I think you just have to have a good support system, whether that just be other people with babies and knowing what their babies are doing, and then the EI therapists or outpatient therapists. Many of the NICUs have developmental follow-ups if your baby qualifies for that. Sometimes that's just for the itty bitties that come through. It changes. It depends on the baby. Yeah, I don't know what else to say about all that, but there's lots of things you can do early on. So even though your baby comes in and it's, at least what I see, I would imagine it's very frightening seeing all these different things and different people you didn't think you would ever meet. But there's always, like, it's positive things moving forward to get your baby home. And that's our job as therapists, is to promote normal development and to promote positive interactions between parents, caregivers, and their baby, and to get you home. So that's my goal. Do you guys have any specific questions or anything maybe I didn't touch on?